We're at the 2019 CROI. We're here in Seattle with David Back from University of Liverpool in England, and we really appreciate you taking the time to visit with us. It's been a very interesting conference, and I caught you in the hall and I thought we really need to talk about maybe how far we've come with some of the thought processes that got us into answering questions in the old days and how we've evolved. And I just give us a sense of that, because it's so important to understand how we've made the changes that were necessary as time moved on.
Well, thanks very much. It's been a privilege to be involved in this field from the very beginning. I can go back to the late 80s when we were approached by our Medical Research Council to just give some support to the first trial, which Concord and Delta, Zidovudin and Zidovudin plus DDI and DDC. And the evolution, particularly when you look at some of the pivotal findings and pivotal moves in therapy through Vancouver 1996 with protease inhibitors. And I think my interest as a clinical pharmacologist was then to realize some of the exciting developments, but also some of the complexities that multiple pills multiple times a day, and also from a perspective of having co-medications which would lead into drug-drug interactions. And how could we then manage what was beginning to seem to us as to be often a difficult process, because with different drugs, different potential for interactions. And so we started to evolve strategies of, one, could we monitor patients with their blood levels and therapeutic drug monitoring? And also then to try to give some resources to healthcare professionals and to patients to be able to see that drug-drug interactions could be managed, that they were real, but we needed to be able to manage them. And so that process, from a perspective of trying to have information available which would make that process easier.
Yeah, there's so many things that have changed over the years, and I know that you were, I should say were and still are, committed, and it was a challenge to go through this process of the thought process of how do we get people to make sure they do take their treatments, because like you said, I guess some of the people were taking like 17 pills a day. And
even more. I think I have pictures of 25, 30 pills a day.
But I mean, you literally had to take, and then of course if you were like cardiovascular and all the other things to do. And that was, we called that pill burden. We had a lot of folks that just said, I can't do that. Well, there's no choice. No. You've got to do this. Now we're down to one pill a day, at least as far as HIV is concerned, and maybe going into injections, which could be, who knows what, 2 or 3 months, potentially, or some sort of insert into your fatty tissue where it would come out as a slow process. But the work that you did was revolutionary, because the one thing that with the TDM we really were concerned about was actually, were we getting precisely what the patient needed, because at the time the side effects were so critical. That's right. And you wanted to not give more. You thought, well, if this person was getting too much drug, that was why they had the side effects. So we should give them less. We could dose it out so it was exactly the dose that they needed, or more precisely the dose they needed. And that would save them the ability to get actually on that treatment. And we worried about that. Now the situation is that the drugs are so less problematic. You don't have to worry too much about toxicity or dose toxicity. So it's a big change. So and the other thing that I wanted to broach with you is the fact that people like yourself have been around, like you said, since the beginning. And you've gone your whole career in this field. And we respect you and honor you for that. And I don't know if you want to say anything to some of your colleagues that have done equally strong commitments to the field.
No, it's been it's been a real privilege to be in this field. For me, the last year or so has seen two really highly respected colleagues like Mark Weinberg and David Cooper, who have been really at the forefront of so much of the effort in treating HIV. To lose those colleagues, and as I'm approaching, I guess, towards the end of my career, And looking back, to go from the kind of complex medications, as you said, to one pill once a day, and then now to project forward to some of the exciting developments of once a month, once every 2 months, once every 3 months. I guess we couldn't foresee that. You know, when we started out, we couldn't foresee where this field was going to move.
Well, we'd always hoped that there would be a cure.
Absolutely.
But in absence of a cure, we've gone and done what we could antivirally, so
sure.
It's comfortable, and it's the drugs, I don't want to say they're innocuous, but they're close to that. And we're finding a lot of people that are casual about the whole thing.
Yeah.
And I want people in the audience to understand this is a long struggle, a hard struggle, hard fought, and it took doctors like you to say, hey, we can maybe make a change here that's going to improve the access for people that otherwise couldn't take the drug, and a lot of that happened more in Europe than it did in our country.
Yeah.
But it was still a very important step, I think. At the
One of the things I've always said, I come from Liverpool, and the Beatles came from Liverpool, is that we can work it out.
Yes.
As long as we work 8 days a week,
yeah.
and it's going to be a hard day's night. So it's that
a lot of cliches in there.
A lot of cliches there, but that's always been a mantra that we really need to work as hard as possible. Our patients deserve the best possible treatment.
In that regard, and we don't want to see you retire. We want to see you keep on going. But there are so many young people that are in the field today, and I don't know, you probably see them in the poster sessions.
Yeah.
They're a lot less than I saw the last time, but truly they are committed.
No, they are.
And I'm impressed.
Yeah.
I'm impressed.
I mean, I look back and I've had the privilege, I think, of seeing 75 graduate students get PhDs or MDs, and then go, many of them, into developing their own careers within the field, and to actually begin to make inroads in areas which are going to make an impact. And that's, for me, a rewarding, exciting thing to see people want to stay in this area.
And that's what I've been hearing this conference.
Yeah.
A lot of earlier on, I've heard a lot of times, I'm not sure if I want to stay in the field, or I know I want to go off this way or whatever. Every single one that I interviewed this year, or talked to, said, I'm really committed. I saw what it is. I had good mentorship on direction, and this is where I want to go.
Yeah.
I'm committed to this.
Yeah.
So
and I think it may be different to maybe a couple of years, 2 or 3 years ago. I think I've seen a change in the last few years that there are exciting developments both in the treatment paradigm and cure as well.
And they can see a future for them in the future for that particular paradigm or disease.
Yeah, no. And also, I think one of the great things at this meeting is the link with, tuberculosis, and that we're bringing together people working in different fields of infection. HCV obviously is something which we've seen many advances, but it's not done. We're not done. No. We're not done.
And that leaves a lot of people taking the initiative to make those things get done.
Absolutely. Absolutely.
Yeah. So David, thank you so much for being here.
Thank you.
It's always an honor to interview you, and we can remember the good old days, and we'll have a lot of good new days. And I hope to interview in another 10 years, and we're going to.
I'm not sure that I'll be here in 10 years, but
I'm not sure
you never know.
Here in 10 years, but you never know.
You never know.
You're right.
You never know.
You can only hope.
Thanks very much.
So much.
Privilege. Thank you.